Welcome to another Practice Medical Cases with MedicoMedics. A 58-year-old man comes to the clinic due to progressive exertional chest discomfort for the past 3 months. He describes the pain as a pressure-like sensation in the central chest that resolves with rest. He has a 35-year smoking history and a past medical history of hypertension and type 2 diabetes. Physical exam is unremarkable. Fasting lipid panel shows elevated total cholesterol, elevated low-density lipoprotein, decreased HDL, and elevated triglycerides. Now, which of the following best explains the pathophysiology underlying this patient's disease? Is it infiltration of vascular media by eosinophils? Is it proliferation of smooth muscle cells and deposition of extracellular matrix? Or is it immune complex deposition in the intima of large arteries? Is it acute vasospasm triggered by autonomic dysfunction or excess collagen degradation by matrix metalloproteinases? Please feel free to pause the video for a few seconds and see if you can figure out the right answer. If you've selected B, proliferation of smooth muscle cells and deposition of extracellular matrix, then you are correct. Now, why? Well, atherosclerosis is a chronic inflammatory disease of the arterial wall that leads to the formation of atheromatous plaques, primarily in large and medium-sized arteries, such as the coronary arteries, carotid arteries, and renal arteries, for example. Now, the entire process begins with endothelial injury, triggered by risk factors like hypertension, diabetes, smoking, and of course, hyperlipidemia, as we see in this clinical example. Now, in response to the endothelial injury, low-density lipoprotein particles, so LDL particles, enter the intima layer, and they become oxidized, attracting monocytes, so immune cells, which differentiate into macrophages. These macrophages engulf the oxidized LDL and turn into foam cells, forming the fatty streak. This is the earliest visible lesion of atherosclerosis. Now, over time, vascular smooth muscle cells migrate from the media layer to the intima, where they proliferate and secrete collagen, elastin, and proteoglycans, forming a fibrous cap over the lipid core. And this leads to the narrowing of the vessel lumen, and therefore the reduced blood flow. And this is what we then see in patients with, for example, stable angina. Now then, why is it not alternative A, infiltration of vascular media by eosinophils? Well, this actually describes eosinophilic vasculitis, also known as Churg-Strauss syndrome. So it doesn't it doesn't describe the chronic inflammatory process seen in atherosclerosis. So the key thing here is that there is no eosinophilic predominance in atherosclerotic plaques. What about alternative C, immune complex deposition in the intima of large arteries? Well, this mechanism is typical of immune complex mediated vasculitides, like, for example, polyarteritis nodosa, so PAN. Key here is that atherosclerosis is not immune complex driven. Alternative 4, acute vasospasm triggered by autonomic dysfunction. This is, for example, seen in Prinzmetal, the variant of angina, where transient ischemia occurs at rest due to coronary vasospasm. Now, this is not right because this patient that we have here has exertional symptoms, and a fixed stenosis could be seen on an angiography. And this is more consistent, of course, with atherosclerosis. And finally, excess collagen degradation by matrix metalloproteinases. Well, while these MMPs are involved in plaque rupture, leading to acute coronary syndromes, This patient here has stable angina from a fixed plaque. So it's not plaque rupture. So all in all, it's not the primary mechanism in chronic atherosclerotic narrowing. Now then, just our high-yield review for atherosclerosis in general. So the cause, typically chronic inflammatory response to endothelial injury in medium and large arteries, leading to lipid accumulation, foam cell formation, and smooth cell proliferation, leading to the formation of plaques, and therefore luminal narrowing, as you can see in the illustration here. And you can probably intuitively understand that when the lumen is clear and free like this, blood flow will be much smoother. But as the plaque grows, the resistance of the blood flow will elevate and increase more and more. Typically due to causes like hypertension, smoking, hyperlipidemia, diabetes, obesity, etc. Symptoms could be stable angina, so exertional chest pain, which is relieved by rest, which is an example we have in this case, right? Because, as we said, he describes the pain as a pressure-like sensation in the central chest resolving with rest. We can also have intermittent claudication, so leg pain with walking. And we could also see transient ischemic attacks or stroke, etc., etc. Now, what about diagnoses? Well, elevated LDL, low HDL, and high triglycerides. This is all confirmed in our table right here. We had an elevated LDL, decreased HDL, and elevated triglycerides. An angiography can show stenosis or occlusion of the affected vessels. In our histology, well, we mentioned here foam cell formation. So we would discover foam cells here and the fibrous cap. What about treatment? Well, lifestyle changes is prio, so smoking cessation, for example, exercise, healthy diet, anything to keep your cholesterol levels more stable. We can, of course, implement the use of statins to lower LDL. Furthermore, if it's more severe, we can turn to surgery, so we can do stenting and bypass for severe occlusions. But it's mostly done in prevention. So treat the hypertension, treat the diabetes, treat the dyslipidemia. And that's the end of this case example. Until next time, keep it clinical.